Uh, Good evening. No, good morning rather. Uh, I'm making this presentation because tomorrow uh, I might be in a CHID meeting, to be in the physical therapy department of the AMCI or Adventist Medical Center Iligan because of the CHID requirements, which requires my presence as well as the presence of the clinical coordinator in uh, clinical coordinator in the presence of in the uh, presence of Dr. Sonyeka, no, or in the absence of Dr. Sonyeka. Uh, okay, to start our lecture, uh, our topic for this morning is about coronary artery disease and cardiomyopathy. Of course, we have already discussed this last time, but to formally uh, share it with you, I made this presentation. So, artery disease is also known as arteriosclerotic heart disease or coronary heart disease. So, it is a progressive disease process that begins in childhood and becomes clinically apparent in mid to late adulthood. So, when you have a coronary artery disease, it starts in uh, early childhood, which means the buildup of plaque formation or the buildup of plaque in your blood vessel starts from the childhood. So from here, it is very important to take note. It's very important to monitor the diet that we feed to our children because in the long process, this will affect the coronary artery of their heart, which will eventually lead to disease. During the early phases of the disease, there is an outward expansion of the external vessel to compensate for the plaque growth inside the lumen. So later on, this plaque growth would overcome or will outgrow the size of the vessel in which the remodeling of the vessel becomes impaired. Uh, so the clinical spectrum of COD ranges from silent or asymptomatic to marked myocardial ischemia to chronic stable angina to unstable angina or acute coronary syndrome, acute MI, chronic ischemic cardiomyopathy, congestive heart failure, and sudden death. So this is the spectrum of CAD. No? When you say spectrum means it is the coverage of CAD. So from asymptomatic ischemia becomes a chronic, then unstable, becomes acute coronary syndrome. Then you will now go to MI. It can be a chronic or an ischemic MI, then cardiomyopathy or abnormality of the muscle because there's already an MI, then heart failure, then eventually death. So this is the major risk factors of the cardiovascular or the coronary artery disease. So it starts from family history. So family history means it runs in the family. Lifestyle, cigarette smoking, no, negarillo, especially if you have just quit within 6 months. So usually you're prone to this. Hypertension, when you have a systolic blood pressure of more than 140 and the systolic blood pressure of more than 90 millimeter mercury, or taking a antihypertensive medication as maintenance. Then dyslipidemia. So if you have increase of LDL and HDL cholesterol level, so if you notice, they have If your LDL is more than 130 milligrams per deciliter and your HDL is less than 40 milligrams deciliter, or taking a lipid lowering medications. No? Impaired fasting glucose. If you have a fasting glucose of more than 100 milligrams per deciliter, in which it is already categorized as you have hyperglycemia. Obesity and overweight. So as we all know, when you say obesity, if you have a BMI of more than 30 or a circumference of more than 40 for males and more than 35 for females. Sedentary lifestyle. So if you are not participating in exercise program or not accumulating of more than 30 minutes of moderate physical activity or most of the days of the week, then you have a history of cardiovascular disease. So if you have already a history of angina, myocardial infarction, or PTA, peripheral arterial disease, or PAD, peripheral artery disease, TIA, or ischemic stroke. Of course, there are other factors, but these are major risk factors. No, I mentioned, and there are other factors: increase of triglyceride, thrombogenic hemostatic factors. When you say you have problem with your clotting factors, infection or inflammation, ethnic and socioeconomic, so very common in African Americans, non-Hispanic whites, Hispanic Americans. Then psychosocial, if you are mentally depressed, mentally stressed, chronic hostility, social isolation, so you are prone to developing a coronary artery disease. Uh, Alcohol consumption, palainom ka, and other medical conditions, no, which could lead to these conditions such as RA and systemic lupus erythematosus or LSLA. So let's go now to myocardial ischemia. So I mentioned it already before that myocardial ischemia, you say ischemia, there is just a decrease of oxygen supply to the tissue. So the blood supply or the oxygen supply is not totally cut off, but rather you have only a limited amount of oxygen supply. So therefore, the the supply could not meet the metabolic demand of the muscles or the myocardium, which can be induced by excessive myocardial demand. And because of this, there is a what will happen to you? Of course, your uh, heart activity will decrease. No? So during a demanding activity, this angina will be provoked, no, because there's an increased demand of oxygen in that area, and then there's a little supply of oxygen, so therefore you may be exhibiting a unstable angina or stable angina, no. But usually in myocardial ischemia it is still asymptomatic. Pathophysiology, there's an imbalance between myocardial oxygen supply related to the demand, which typically occurs during exertion or emotional stress, with luminal narrowing of more than 65 to 70%. So actually, manifestation of myocardial ischemia will happen if the narrowing of your blood vessel will reach 65 to 70%. So if you have only a little narrowing or a little occlusion or a thickening of the blood vessel, be it secondary to deposition of the thrombus of less than 50% or less than 65%, therefore there will be no manifestations that could be seen to you, or you will become asymptomatic. So there are several conditions that will happen if reperfusion re, reperfusion of blood happens no? After ischemia, then there is an immediate reperfusion. Then usually your heart will undergo myocardial stunning. When you're myocardial stunning means uh, there will be delays in recovery of contractile function because your heart muscle will be shocked, or sometimes it will cause more injury if there is a sudden, no, restoration of blood supply to the area who suffered from ischemia. Then usually it would, instead of healing that area, it will add more injury. No. So the next one is myocardial hibernation. So there is a repeated episodes of ischemia, reperfusion, which can induce a state of depressed function of the myocardial muscles. We call that as hibernation. Means your heart will not gain its function after revascularization. Murag matulog sa ang imong heart, no, for several minutes or hours, then slowly makamata siya. No. In myocardial stunning, nakuratan. No. Ikaw bitaw makuratan unsa man, matulala baya ka. So mao gyapon nato kasing-kasing. No? Kung makuratan siya og balik dayon sa supply, matulala po na siya. No? Clinical manifestation of ischemia or myocardial ischemia. So you have angina pectoris. So you have a chest discomfort. Classic characteristic which includes the following, no? Pain type. So there is a pressure or heaviness, squeezing, tightness, and burning. There is a chest. Location, substernal. When you say substernal, that is below your sternum. And in the jaw, pating jaw. Sometimes even a person who is suffering from angina, naslay murag jaw, no? Shoulder, epigastrium, to diri sa imong tuwa-tunga, ano? Sa imong epigastric area. Then back or arm. So dira ang pain, shoulder, back, and arm, no? So even sa jaw or sa sternum. It is precipitated, means precipitated masamot siya kung nakay exertion, if you're under stress, or emotional excitation, and meals. Kung magkaon, busog. No? Duration usually 3 to 15 minutes. You will be relieved by rest or mitigation of stress or by taking NTG or nitroglycerin. And usually in between na ay pain-free. No, mawala, niya mabalik. So inana siya, no, ang manifestation. Now let's go to acute coronary syndrome. It is used to best describe patient who presents to the emergency room with an either acute MI or unstable angina. So if you have now an acute MI, gina ischemia pa man to. When you say MI means nana siya obstruction yun, or unstable angina. When you say unstable means ang iyahang intensity sa pain, ang occurrence, location, pabalhin-balhin na siya. No? The most common cause of ECS is rupture of non-calcified atheromatous plaque that is less than 50% occlusive, followed by formation of superimposed thrombus. So, mo na siya kasagara niya. So, pasabot katong gahi na nga plaque nga nasa imong blood vessel mo rupture. Nya pag huwag rupture kato iyang gibiyaan, okay, masamad man to, maglangkat, parehala ko ng kugang nga nagpilit pa dito sa imong panit niya, imong tanggalon ang kugang diretso, sa may mahitabo, di ba, mag-bleed. So kung mag-bleed na, sa may himuon sa atong dugo, kay naaraman siya dito sa agyanan yun sa dugo. So you have clotting formation. So na thrombus formation dito sa area nga nagkuhan. So usually, ang pag-form sa thrombus is mas dako siya compared atong natanggal. So, mahitabo, mas masamot ka narrow ang agyanan sa dugo. So, therefore, there will be obstruction. No? So, usually, myocardial infarction, mahitabo lang siya if the interruption of blood supply to an area of myocardium for 20 minutes or more. So if there is a decrease or absence of blood supply in your cardiac muscle for more than 20 minutes, that's the time that you could say there is an MI and tissue necrosis will happen. In more than 80% of cases, MI is precipitated by thrombosis due to disruption of fibrous cup or superficial erosion of the endothelium. So here, muna to na akong gimension nga, pag matanggal tong atheromatous plaque, ang iyang gihawaan na samad man to, na erode, mo to siya, mo-trigger dayon siya o clotting formation. And less often, it is produced by coronary spasm, embolism, and thrombosis in the normal coronary artery. So we have two types, no? Na-mention na nako. You have your ST elevation myocardial infarction, which is the most lethal form of ECS, and non-ST elevation, which is diagnosed in patient with ST depression. And usually, ang non-ST elevation, kani siya asymptomatic. It can be only detected by biomarkers such as troponin and CK or your creatine kinase nga enzyme sa imong blood. Okay. Sa ST elevation, it is lethal. So therefore makita gyud nato nga naay necrosis na, no, sa imong cardiac muscles. So this is an example of an ECG with ST elevation. So we all know now that this is your P wave, diri. P, then this is the QRS complex. Okay, so ang ST nimo, this is the S, this is the T. Imagine that. This is already elevated. Okay, usually in normal ECG, your ST wave is dira na siya sa ilalom, no? Dira siya sa gaana siya. Pero this time taas siya, no? So this is a classic example of STEMI or ST elevation myocardial infarction. Okay, so this is another view. So you have here the PQRS. This is the ST segment. Okay. So inana. So mangita sa STEMI, mao ni ang resulta. Grabe ka elevated. Sa non, mao ra ni ang ST depression niya is elevated, no, compared sa diri sa PICAS. Nasa ST depression. So when you say ST depression, kani, no, S and the T, no, the boss, kani elevated, no. So inana siya. So this is non-STEMI, or this one, this is an inverted, no, of T wave. Again, that is non-STEMI. Pathophysiology of MI. Okay, the pathophysiology, usually in acute MI, it creates three concentric pathological zones. The central area of myocardial necrosis and the surrounding areas of injury and ischemia, which can give rise to diastolic and systolic dysfunction, which may lead to ventricular dilatation. Okay, of course, the affected part in ischemia usually in the bundle of His, or it is in the ventricle, or it could lead to cardiac heart failure or cardiogenic shock, depending on the size of the infarct. Okay, so inana siya. So it even led to death if there is a cardiac arrhythmias. When you say cardiac arrhythmias, means your heart muscle is contracting very fast, wherein there is no time for the muscle to relax. So murag nanggahi na lang gina siya. So what happened? Walay blood flow nga mahitabo. Ngano man, contract naman siya steady. So walay circulation nga mahitabo. Walay ma-in, walay out ang blood sa heart. So pahitaan na mo. Asa naman ka ana dayon. So welcome to the kuan na dayon dito sa langit, no. San Pedro na pangita nimo. Of course, that's only an expression. So So usually, if the infarct is ruptured, then that would result to septal defect or cardiac rupture or acute mitral regurgitation. We say mitral regurgitation means that your blood in the ventricles will go back to the uh, in the left ventricle will go back to left atrium and eventually go back to the lungs. No? Kay left atrium, mao ang kanya dito man siya gikan sa lungs. No? So kung mobalik siya sa lungs, you will have no pulmonary edema. So you have left side cardiac failure. No? So extension of infarction will expanded area of necrosis. And you will have pericarditis. So this is now the appearance of the heart. So you have here, see this one, this is the one that produces the T wave. No? In the ST elevation. So nakakay inani. So kanang sa to nga mo na imo zone of necrosis, infarct. So infarct ni mo naman gina siya necrosis, matay na siya dira. Then you have your zone of injury. No? Zone of injury. So kani sila diri dili pa na siya patay, no? Kani injured lang ni siya diri. So asa man ang patay ana kana gyud ang sa zone of injury. Okay, ang 3 kani is decrease of blood supply o ischemia lang na siya. So imagine kung motang ta ang zone of injury is about as big as taman 25 centavo. 25 centavo ang zone of injury. So let's take a look at the zone of infarct. 25 centavo ang zone of infarct. So how big is the zone of injury? Magkadako until sa zone of ischemia. So dako kayo ang damage nga or naigo nga tissue sa heart. So therefore, kadako magkayo affected yun ang function, diba? So what will be the abnormalities observed after MI? So first, you have reduced of motion of a myocardial wall. So you will have hypokinesis or sometimes akinesis. You see, akinesis is wala gid siya liho kay imong heart nagpuyo. Or sometimes abnormal movement. So you will have paradoxic motion of a segment which is known as dyskinesis. Anong naamang kay dyskinesis? Or sometimes akinesis or hypokinesis. So, usually kung affected man nimo is ang SI node or ang node sa imuhang kay electrical signals man no, ang conduction niya. So kung naay area na isa ka node nga affected, so what will happen? Dili na to siya mag-function. So therefore, abnormal gud siya. Usually dyskinesis is affected tuod ang flow sa electricity pero man matigom ni makalit lang siya release. So therefore it will make an abnormal movement. Akinesis means wala gyud siya nag-aging electrical signal. No. So ang hypo hinay lang. So inana because of the presence of obstruction or area nga na-injured, no. Okay, clinical manifestation of MI. So of course angina pectoris or chest pain with or without radiation to the arms, neck, jaw, teeth, or back. Panington ka, diaphoresis. Bugnaw pagkita ang paningot, no? Dyspnea, shortness of breath, nausea and vomiting, kasukaon ka, dapat imong ulo, kakuyapon, no? Then lightheadedness, gaan, dizzy, labad, syncope, means magkawala ang imong breathing, makuyapan ka. Apprehension or sense of impending doom. So ikaw mismo na murag na kay gibati nga murag kamatayon ko. So makita ni weakness. But at the same time, deep inside denial ka. Dili koy wala koy kasing. Dili ka mo admit nga naa kay problema sa heart. and eventually sudden death. No. Now, take note, class, 20 to 25% of EMI occur without symptoms. Mo gina kay as I've said a while ago, di ba? Magmanifest lang ang symptoms kung ang lumen nato is na-obstruct siya sa plaque around 65 to 75%. So, 50% na-obstruct. Wala kay symptoms. Yun nga, na-dislodge, nagkalit. Itong atheromatous plaque niya, nag-accumulate din ang thrombus or thrombus formation dito sa nakuhaan niya nga plaque area. Kaya nasamad man. Kalit lang kaayo. So, sudden kaayo. Di ba? Sa lisod. So, other biomarkers is elevated troponins and creatine kinase or creatine phosphokinase or CPK. Oh, so, inan. So, we call this as myocardial band isoenzyme. So, MB. So, mo na siya ginakuha dito sa ato blood vessel. Make sure. So, the next topic is hypertension, which is very common in a lot of patients. So, here, the classification here of hypertension, may hypertension lay aram makaya sa heart because usually patient no mo siya sugod-sugod gyud sakit sa heart no na kay hypertension then affected na dayon dito ang kasing-kasing. So hypertension is defined as a persistent elevation of arterial blood pressure above 140 mm mercury for systolic and 90 mm mercury for diastolic. That is the old classification. May high blood nako kay mao ni pero dili sa new classification of the American Heart Association and American Stroke Association, the AHA and the ASA. According to them, ang normal, makonsider din siya nga normal ang BP nimo if you have a blood pressure of 120 mm, blood pressure of less than 120 mm mercury for systolic, and less than 80 mm mercury for diastolic. So therefore, if you have a systolic of 120 and above, going to 129, that is considered as already elevated blood pressure. Taas na siya. With less than 80 gyapon ang imong diastolic. So inana. But if you have a BP of 130 to 139, then you have already a diastolic of 80 to 89 mm mercury. That is considered as hypertension class 1 or stage 1 hypertension. So kung 140 or higher na ka and your diastolic is 90 or higher, you are now considered as stage 2 hypertension. If it reaches to 180 and your diastolic is 120, then you are already in hypertensive crisis. So, we have classification of hypertension. We have primary and secondary. Okay, when you say primary hypertension, okay, so this is a hypertension diagnosed with no known cause that can be identified. So, risk factors is associated with age, ethnicity, obesity, glucose intolerance, smoking, stress, excess sodium or alcohol intake, decreased intake of potassium, calcium, and magnesium, and lack of exercise. So, if we have an increased BP of more than 129 or 120 to 129 and 80 millimeter mercury, that is considered as with no known cause. This is considered already as primary hypertension. No? Wala gihinungdan. Secondary hypertension, there is a specific cause. No? When you say specific cause, na kay sakit nga hinungdan nga nung itaas mo BP. Maybe you have kidney problems, endocrine or metabolic disorder, vascular problems, neurologic disorders, you're taking various drugs or toxin. An example of that is non-steroidal NSAIDs could elevate your BP. You're taking drugs such as cocaine because cocaine increases cardiac output. Or, not cardiac output rather, but cardiac activity. Then you have also labile hypertension, occurs when BP is sometimes elevated and other times normal. So, labile hypertension, which is very common among us. No? Mataas lang ang BP, kung naikuan din at ito, mawala ra po, maubos. So, that is labile. White coat hypertension, usually very common among us also. Pumunta to sa hospital, pa-check up sa doctor, then our BP increases because we are so tense. We're afraid that the doctors might discover of something dili pleasant para sa tua. So, gikulbaan na ta. So, so we call that as white coat hypertension. Then you have a mask hypertension. Exists when an individual has a normal clinic BP but high ambulatory BPs, which may occur in up to 10% of general population. So, kani sila, at sa clinic, normal ang BP. Pero inig matindog na, mataas lang kalit. Malakaw. So, inana. Malignant hypertension involves markedly elevated BP. Okay, usually causing retinal hemorrhages, exudates, or papilledema. So, nakay problema ng mga cancer, mga that could elevate your BP. No? May malignant ka sakit nimo. Not only cancer, but grabe na. No? Infection could lead to malignant hypertension. No? If you have blood infections, mataas yun ang BP na. Pathophysiology. Okay, so in hypertension, there's an alteration of the endothelial and arterial structure. Mechanical properties and function lead to hypertension, which creates a pressure load on the left ventricle followed by compensatory left ventricular hypertrophy. So, that reduces wall stress. So, inhana siya. No? Ang problema dito gid sa endothelial layer sa imuhang arterioles or arteries. Or sometimes mechanical properties sa imuhang valve, no, sa heart, no, that could result to hypertension. So, addition to that, stiffening of large systemic arteries with age. So, katigulang ka, yung magkagahi ang arteries, dili na siya pliable, so dili na siya ka-dilate o ka-constrict, no, dali, that would result to hypertension, which is very common in aging. Clinical manifestation of hypertension, so you have an accelerated malignant course, cerebral vascular accident, hypertensive heart disease. So, mo ni si kasagara kuan. Kung taas ka BP, naitindi si stroke ka. Atherosclerotic heart disease, sakit sa kasing-kasing, amo tong problema sa agyanan sa blood vessel. Aortic aneurysm, simple or dissecting. You have peripheral vascular disease, retinopathy, fatigue, exertional dyspnea. Siyempre, hypertensive na ka, mag-exercise ka, mag-exert kag effort, mag-aswat kag bugat, taas imong BP. So, sa may metabo, you will have exercise intolerance. Exertional chest discomfort. So, nanakay, ginatawag nila nga, ischemia. Di ba? So, basically, most of the cardiac disease, nag-start lang yun na siya sa hypertension. So, specific treatment if you have hypertension. So, daghan. Siyempre, kung taas ang BP, primary kuan yun mo is kuhaan ang blood volume para ma-decrease ang BP. So, to decrease blood volume, sikag ihi-ihi. No? Inom kag diuretics. Beta blockers, that is for the cardiac activity. Pahinayon ang cardiac activity, or maybe alpha blockers, angiotensin blockers. So, ano, ang activity sa angiotensin mo, which is responsible for blood vessel constriction, yung blakan. So, mahitabo, dilate lang pero may ang blood vessel. No? Then, you have angiotensin converting enzyme inhibitor or ACE. So, ang secretion sa imuhang renin-angiotensin, iyang punggan, gikan dito sa kidney. No? Or angiotensin receptor blocker, i-block niya para dili siya dito makapilit sa receptor para maka-create og vasoconstriction, and vasopeptidase inhibitors. So again, ana. Og ang isa pod ka treatment ani which is free is lifestyle modifications. When you say lifestyle modification, obese ka, siyempre, weight reduction, libre. No? So remember class that weight reduction in every there is a 1 millimeter mercury of decrease for every kilogram of weight loss. So in every kilogram of weight loss, or that is equivalent to 2.54 pounds, or 2.21 pounds, nga decrease na mo, na ay isa ka millimeter mercury nga maiban sa imong BP. Avoidance of tobacco, diet modification, physical activity, stress management, complementary alternative medicine including garlic, autogenic training, and biofeedback in yoga. So, no, inana. May ito sir, yoga? Decrease na, yes, yoga. There are some yoga practitioners that they could even stop their heart activity for about 8 seconds. That's how sila, how deep is their study of anatomy and how to control the parasympathetic and sympathetic nervous fiber so that they could stop their heart. So, inana. Clinical implications of physical therapy. So, if you have a patient who is hypertensive, ang pinaka-critical yun nga i-monitor nato is BP. BP monitoring is very important in clinical in-home program. At the same time also, taking of maintenance meds must be taken usually before exercise. So, inana siya. So, muna siya importante nga clinical implications. Kaya nga naman, if you're not going to monitor this BP and you're not going to regularly check your patient if he's taking his maintenance medication, so what will happen to your practice, to your cardiac rehabilitation program? Mawala. No. Let's go now to cardiomyopathies. So, cardiomyopathies, heart, myo, muscle. So, it talks about pathology of the heart muscles. Okay? Kay pathies or patho. Okay, disease. So, this is a diverse group of disorders that originate in the myocardium of the heart. Okay, so dito na siya nagsugod sa cardiac muscles. So first here, we have dilated cardiomyopathy, which is the most common type, which is characterized by large or cardiac enlargement, impaired systolic function of both ventricles or one of the ventricles, and often symptoms of congestive heart failure. So, ano siya? Kung nakay heart failure, nakay problema sa muscles sa imong heart. So, dilated cardiomyopathy accounts for about 25% of cases of congestive heart failure. So, taas ano? Kung nakay congestive heart failure, nakay cardiomyopathies. So, about 25%. Pathophysiology. So, usually, ano bang problema ka sa cardiac muscles? Because of infections, non-infectious, or inflammatory processes. So maybe like toxins or nakaon mo mga drugs that could affect your heart. No? So you have alcohol and drugs, maybe pregnancy, postpartum because of the change in the uh, hormones, no? Metabolic disorders, okay, nutritional disorders, altered metabolism, or hereditary gikan gyud sa pagkapanganak niyo. They may cause dilated cardiomyopathy. So, ang iyang features ani, ang inyong panahon ina, defective ang imong left or right ventricle or both ventricles. So, na clinical manifestation. So, of course, you have dyspnea, and usually it is exertional. No, sa sugod-sugod, when you say exertional, kung mag-exert lang kag effort, nakay shortness of breath. But later on, even at rest, no? Kaya siyempre, hapit naman mo failed ang heart, no? Nocturnal dry cough. Nocturnal means night, gabi nga ubo, no? Dry. Nakay signs and symptoms sa left ventricular failure. Naapod kay possible signs sa right ventricular failure. Chest pain on exertion. Left ventricular impulse displays lateral to mid-clavicular line. So if you do auscultation, no, sa imong left ventricle unta siya diri sa imong left, no? Madunggan nimo ang heartbeat niya sa imong left ventricle. Mobalhin siya diri sa tunga sa imong supposedly na siya sa dual sternum. So na kay S3 and S4 gallop rhythm. Inyo si gallop rhythm murag ang di ba you have S1 the first sound, S2 second. Ang S3 S4 supposedly hinay na siya. Pero instead yung hinay murag tiil noon sa kabayo nga mag ana. So that is a gallop rhythm. Paspas. Magkabayo. Systolic murmurs of mitral and tricuspid regurgitation. So, pwede na siya mo regurgitate ang blood, mo balik dito sa atrium, left and right atrium. So, kung mabalik siya dito sa atrium, mo stuck ang dugo dito sa lungs o peripheral. So, both na kay peripheral edema and na kay pulmonary edema. No? So, ina na siya. So, na kay arterial enlargement, no? So, sugod-sugod, pero eventually, mapaingon na siya sa peripheral o sa pulmonary. Decreased QRS. The QRS complex is decreased. Non-specific ST and T changes on ECG. So, dira mo siyang tanawon sa imaging, makita nimo siya na sa cardiomegaly or enlargement of the heart. Basically, ang ni-enlarge niya is, kung na sa regurgitation, ang ni-enlarge niya yung portion is your atrium. No, nganong dili man dito sa ventricle? Kay ang ventricles nimo nag-hypertrophy man, nibaga. Subot pa sabot. Dili siya muburot kay stiff naman to siya. No? Gahi, so di siya muburot dito ang imong ventricles. So instead, ang maburot nimo is the atrium kay ngano nagregurgitate man ang blood paingon dito niya ang imong atrium, ang iyang muscular layer ana, it is not as thick as the muscle sa ventricles. So murag balon gyud siya mubulon. No? Hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is characterized by considerable unexplained increase in cardiac mass. So mubaga ang iyang muscular wall or ang myocardium nga layer. It can be asymmetrical or asymmetrical. No? Symmetrical siya or asymmetrical without cavity dilatation and normal or hyperdynamic systolic function. So, walay dilate sa imuhang cavity. or sa imo ditong sa sulod sa ventricles, no? Wala. Ang nibaga lang, ang muscular layer lang, no? Pathophysiology, left ventricular uh, left ventricle hypertrophy results in diastolic dysfunction due to abnormal left ventricular relaxation and distensibility, which results in decrease of left ventricle compliance and increase left ventricle filling pressure. So, kung nag-hypertrophy naman na siya, mahitabo kung uh, sudlan siya og dugo gikan sa atrium, dili siya dayon-dayon mopuno kay ngano man taas man ang pressure within the ventricular or within the ventricles nga chamber. So, uh, dapat ang imong atrium, the left atrium nimo mag-contract gud siya para ma-push gud niya ang blood na mosulod didto sa ventricles. I-overcome niya ang ventricular filling pressure. So, nanay dako nga effort ang imong atrium. Yeah, remember nga ang atrium ang ihang muscular wall dili siya parehas sa muscular wall sa ventricles. So, mo balloon siya, mo burot. The signs and symptoms of HCM vary widely, even on a day-to-day or hour-to-hour basis for the same individual, and are partially dependent on the extent and severity of morphologic abnormalities, rate of progression, and presence and degree of obstruction. So what does it mean? Bot pasabot, ang signs and symptoms sa hypertrophic cardiomyopathy, dili siya fix. Especially sa imaging, tanawon mo, sa first nga image makita ka, hala, ni-enlarge ang atrium. Pag sinugin, uy, normal naman na iyang heart. Wala naman siya enlargement. Wala na may ballooning sa atrium. Oh. Kaya nga, vary siya day to day or hour to hour. So, lisod siya na. Tagda. But of course, naa siya dyspnea, naa siya angina pectoris, fatigue and weakness, and presyncope and syncope. Ay mga naa siya presyncope, no? Ma-feel po niya ang impending doom. Ay, later on, makuyapan yun. No? And palpitations. Specific treatment, so these are the pharmacologic management. And I know you are going to discuss this with Ma'am Albino, no? Because you have already pharmacology and rehabilitation. So you have their pharmacologic agents. Nga ginatake na to is beta-androgenic blockers, calcium channel blockers. Again, nga naman kinalan siya, kaya siyempre hypertrophy na ang muscle. So dapat ang activity niya dili siya sama sa activity kanadto kay siyempre kung ma-exert ang ventricles og normal exertion, mas dako gid siya didto sa atrium, no? So na tendency nga dako gid ang pressure niya dira sa ventricle chamber sa ventricles kaysa dito sa atrium. So na tendency nga mag-regurgitate gid siya or mo backflow ang blood sa ventricles going to the left atrium, no? So inana. So dapat ang iyang activity dili kay paspas. So take a mga inhibiting nga klase sa drug. So calcium blocker, beta-androgenic blocker. No, so ibanan pagid ang blood volume. So you have diuretic, no? Anti-arrhythmic and prophylactic antibiotics if you have infection muna nga kay siyempre dito sa imong diba sa sugod-sugod, diba ang cause sa cardiomyopathy is infection. So tambalan, you have restrictive cardiomyopathy. Ang restrictive cardiomyopathy is you have endomyocardial or myocardial disease, infiltrate or non-infiltrate, that can lead to restrictive cardiomyopathy, which is characterized by diastolic dysfunction associated with reduction in ventricular filling caused by excessive rigid ventricular walls. So, problema ani niya, ang ventricular walls is nag-rigid. So, kung rigid siya, ang movement ana niya is restricted. Hindi na siya contract maayo, no? So, mo na siya restrictive cardiomyopathy. Pathophysiology, kay di naman siya contract o di naman siya ka move maayo kay rigid man. So, what happens? Impaired ang ventricular filling niya. So, pasabot, kung gikan sa atrium na ay dugo nga mosulod sa ventricles, dili siya kasulod tanan. Kay ngano, dili man siya dito mainat, kay rigid man. So what happens? Na ay mga mabilin nga blood dito sa atrium, specifically sa left atrium, no? Kay di man niya tanan-tanan ma-empty ang iyahang sulod. Kay ngano, dili naman nimo expand. Kay supposedly mo expand siya to accommodate, no? Plus to increase its compliance, no? Di ba? Matod pa sa Frank-Starling law, kung unsa kuno kadako ang gi-stretch sa cardiac muscle, mo pud na kuno kakusgon niya nga pressure mo apply niya kung mo contract na siya to force the blood going to the aorta or going to the lungs. So, inana. So which are reflecting but in atria, causing atrial enlargement, and then to the lungs or systemic venous, causing congestion or pulmonary edema. So, inana siya. So, clinical manifestation, muna na siya. Pero parehara na sila tanan sa cardiomyopathy. No? So, inani siya ang illustration. So, you have here a normal heart. This is dilated cardiomyopathy. So, notice the ventricles. This is hypertrophic cardiomyopathy. So, you notice now the left atrium, nagballoon, no? Nag-inat siya. Kani siya kay nag-hypertrophy, no? So, ma-regurgitate yun na siya ang blood. Every time nga mo contract ni, kusgan siya. Okay. Imagine, dako, nibaga na ang cardiac muscle niya. So, nana. Then, you have here the stiff restrictive. So, ka-restrictive man siya. Whatever content ani, pag sulod diri, dili ni siya mo inat. Pag dili siya mo inat, dili siya mo expand, what happened to the content of the atrium? Wala, no? Mobilin siya diri. So, mo tadawon, mao sila manifestation nga duwa. Ang restrictive and hypertrophic. No? Okay. Clinical implication for physical therapy. So, inani siya class. So, if you design the program para aning na mga problema sa heart, imong gitigamnan nga usually your exercise intensity is symptomatology. When you say symptomatology, dapat tan-awon nimo siya dito sa symptoms. Kung mohatag kag exercise, mo gawas ang symptoms, automatic stop the exercise. Or even wala pa ka nag-exercise na say symptoms, then don't do the exercise, no? Sa manang mga symptoms such as dyspnea, which typically allows low to moderate intensity exercise of 40 to 75% of peak oxygen consumption. So, ang imo lang, ang ihatag niya is MIIT or moderate intensity exercise at 40 to 75% of peak oxygen consumption. I think we have Carnovian's formula to compute for this, no? Okay, then you have interval training with brief rest period. So, ang importante kung naa na kay moderate intensity training, ang interval na po niya. When you say interval, kanus siya mag-rest. So, imo siya tagaan og brief rest period. Okay. Although, ang imong exercise is 30 minutes, so dapat imo siya tagaan siya og rest period ra. Bisan mugbo lang. Exercise ka og 2 minutes, rest kag 1. Another 2 minutes, rest kag 1. Basta kay frequent and brief, no? Just allowing the heart to become stable, no? Then, importante ang warm up and ang cool down periods. Okay, for patient with heart failure. So, ang imong intensity is low to moderate intensity resistance training, which is very beneficial for this. Okay. So, resources. Uh, this is taken, the lecture was taken in the Cardiovascular and Pulmonary Physical Therapy A book by Wache, okay, in 2009. Okay, so assignment. Okay, assignment. This is what you are going to do. Find a journal that supports the use of low intensity interval training, or we call that LIIT, low intensity interval training, and moderate intensity interval training for patient with cardiac problem. Journal. So when you say journal, so it might be from NCBI, from APTA, from sports therapy. Okay. So dira, no, pangita. No, pangita mo journal each, and you explain it how the researcher used the LIIT and MIIT, or moderate intensity interval training, how they use it in their study to improve the cardiac patients' quality of life. No? So, inana ang inyong assignment class. Ang deadline, when you are going to pass this, you are going to pass this next meeting, which is next virtual class, which is Tuesday next week. No? Okay? So, okay na siya. If you have any question, just PM me in our group chat or sports therapy. Dito sa atong group chat sa sports therapy, dito ko ninyo i-PM for further clarification of this assignment. Thank you for listening. May the Lord bless us.